So let's talk about the complete history and examination in patients with overactivity of the bladder. So history is very, very important because you have to state your goals and expectations, which is important because then I need to see those goals and expectations to see whether it is achievable. Then how long have you had overactive bladder? The duration, what symptoms exactly? Is it just urgency or urgency leakage? What treatments have been tried? What medications you're on for other medical conditions? Do you have any allergies? Any pertinent surgeries or procedures you've had in the urogynecologic area or even the gynecologic area? And they will have you fill up our complete forms, including the questionnaires. So the medication list that you should provide us must be complete. And I've stressed this in my introduction video, and I stress it again, especially here, because let's say you're taking a medication like Prozac or fluoxetine for depression. Now that may interact with the liver enzymes. So it slows down the liver enzymes, and an overactive medication that is broken down by that liver enzyme will no longer be broken down, and therefore it'll stay in the body longer, and you may have an overdosing of that medication. So it's important to know what drug you're taking, and that will help us prevent these errors. So the history should be complete. And again, information about your medical history is important because medical conditions also have a bearing on overactivity of the bladder. For example, uncontrolled diabetes and a high hemoglobin A1C produces more sugar in the urine, more frequency, and affects the bladder, and you can get OAB. Heart problems, same thing. Congestive heart failure can get overactive bladder, and sleep apnea, same concept of nighttime frequency. Then if there's early onset dementia, then I have to be careful not to give you certain medications. Then goals you should define clearly, and we'll discuss the goals once we have the whole picture, your history, your medications, your medical comorbidities, my examination and my testing. Once we have everything, including the diaries and the urodynamics and everything, we can then talk about what are realistic expectations. In summary, without a completed history, your care will be incomplete, medical errors can happen, and we can get drug interactions, especially when you have, let's say, even a high heart rate that you have tachycardia. Some of the drugs that are given for overactivity of the bladder can make the heart rate go up, and over time, it is known to increase mortality. So we don't want that. Questionnaires are very important. The MESA questionnaire defines that urge segment compared to the stress segment. Then the UDI-6 questionnaire, which is also part of your one question called the PFDI, that goes over different aspects of it. And when you follow up, it'll give you this short form OABQ, which is a very simple questionnaire that just goes over, do you have a sudden urge to urinate with little or no warning? And then we can see if it was a great deal and now after medication, has it come down? And it's not just the medication, it's overall management, and we'll talk about that. Examination is important, examining in the lying down, the standing position. We'll talk about that in a second. Getting a urine analysis, scanning the bladder to make sure your bladder is empty. And it's important to make sure that there's nothing falling out on an examination, or there is no fibroid pressing on the bladder, which is therefore decreasing the ability of the bladder to fill up and causing increased frequency. In case of prolapse, the urethra, the tube can get kinked or bent, the urine is not coming out, and that can cause increased frequency. Once we've done the history, the examination, then the testing is very important. This is now done standing up, but that'll tell me as the bladder is being filled up, does the pressure go up like this? And if it goes up, that means I know that there is something wrong, and then you have urgency incontinence. And we'll know when it is happening, and we can also assess when do you empty. So we'll see the capacity of the bladder, when does the leakage happen, and finally, how well do you empty? In some cases with irritability, it's good to look at the bladder to make sure there is no lesion in the bladder. This takes less than a minute to perform, and it's done, but at least we have peace of mind that it's okay. One test that you may have done or may not have done yet, it's voiding diaries and intake log. That's also very important. When you go to my website, under the educational seminars and tests, you will see this video on voiding diaries. And it's a 24-hour diary that you'll be keeping along where you measure how much you put out, and you don't have to collect. So here it's okay, 350, you throw it out, and then you fill up again. The 3-day diary will tell us how many times you're going to the bathroom and if you have any episodes of urgency or urgency leakage. In short, it is very important to do a thorough history, physical examination, and urodynamic testing and cystoscopy and voiding diaries to come up with a proper plan. The history is important, your goals and expectations are important. Once we have all this, then we can go to the next step, which could be basically trying to understand how do we manage this. So the management also is a multi-pronged management, and the management depends again upon the full evaluation. Once we have the whole evaluation complete, the entire evaluation, history, exam, testing, diaries, urine analysis, maybe urine culture, your post-void residual, the whole thing, then we can come up with the next step, which is management. Talk soon about management.